So this is your adrenal glands. As you can see, they are very small and there's two of them. So it sits above both kidneys. So you have the left adrenal gland sitting above the left kidney and you have the right adrenal gland sitting just above the right kidney. The adrenal gland consists of the cortex and the medulla. So the cortex, or the outer layer, is approximately 80% of the entire gland. So this is the cortex right here. And just so you know, medulla is also pronounced as medulla. So you can hear either or, medulla or medulla. And your medulla is the inner layer. The adrenal cortex is responsible for the adrenocortical hormone, including corticosteroids, which are all derived from cholesterol. So these are lipid hormones. Mineralocorticoid and your glucocorticoid. So the mineralocorticoid regulate the mineral, salts, and electrolytes. So the main one that we're talking about here is your aldosterone. So aldosterone is essential for salt and water retention or conservation. On the other hand, your glucocorticoid steroid, cortisol, is basically responsible for multiple metabolic effects. This is also called the stress hormone. This affects gluconeogenesis, or production of or synthesis of more glucose, and lipolysis, or the breakdown of fat. So this affects metabolism of carbohydrates, fats, and proteins. There are disease processes that affect the adrenocortical hormones. Examples are Cushing's and Addison's. So Cushing's is basically the excess in cortisol, and Addison's is the adrenocortical insufficiency. So this is an illustration of a person with Cushing's syndrome. So you can see these are the signs and symptoms of a person experiencing excess cortisol. So this disease process causes redistribution of body fat from the arms and legs to the face, shoulders, and trunk and abdomen. So they have this very rounded face. It is also called moon face, as you can see here. So sometimes this can cause personality changes. There's also gynecomastia in male, so formation of breast tissue in male. And there's fat deposits on the face and the back of the shoulders. Females, sometimes they experience amenorrhea and hirsutism. So basically, this is a disorder, right, causing dysregulation in the hormones. Sometimes you will see striation, bruises, petechiae, and their skin is very thin. This again is a portrayal of a patient experiencing Cushing's syndrome. Addison's disease, or Addison's, or the adrenocortical insufficiency or hyposecretion of corticosteroids. Here, there's a decrease in blood sodium and glucose levels. So there's an increase in potassium levels. There's signs and symptoms of dehydration, and so you will see weight loss. So this is often an autoimmune response, and the adrenal glands stop producing enough cortisone and aldosterone. So as you can see here, this is a person experiencing Addison's disease. So they have this bronze pigmentation of the skin. So as we can recall, the adrenocortical steroids or the adrenal glands sometimes affect the pigmentation of the skin. So as you can see, this is the bronzing of the skin. Sometimes it can cause hypoglycemia. They have postural hypotension, so the drop in blood pressure from changing positions. There's also changes in the distribution of body hair. So this is supposed to be a female, right? But as you can see, there's some facial hair growth, when usually females don't have much of facial hair. There's GI disturbances, generalized weakness, and weight loss. And occasionally, this can lead to what you call adrenal crisis. So adrenal crisis is quite severe. It is profound fatigue, can cause dehydration, severe vascular collapse. So hypotension, the kidneys can start shutting down. There's an extensive decrease in sodium and extensive increase in serum potassium. So this will require hospitalization. So in the case of adrenal crisis, there are diseases originating from the adrenal medulla not functioning correctly. That being said, they're not seen often, so they're very rare. In this course, we don't really need to go over it. So here are examples of adrenal agents. So these are drug examples. One is Solucortef, also known as hydrocortisone. Hydrocortisone basically mimics the endogenous corticosteroids. So this is a steroid drug. This causes anti-inflammatory response, and then also it has salt retaining properties, and so it helps with fluid and water retention. The therapeutic effect of this drug includes modifying the body's endocrine response as well as decreasing inflammation. So again, as we recall, steroids or corticosteroids help in inflammation, so help decrease inflammation. Indications or reasons why we give this medication to patients are mostly for cortisol replacement therapy and as well as anti-inflammatory response. Some precautions and contraindications that we can recall: our side effects for corticosteroids: diabetes, because it can increase your blood sugar; peptic ulcer disease, because it can cause gastric ulceration; and osteoporosis, because it can cause the thinning of the bones from the problem with calcium reabsorption. Side effects are going to be the same as what we've learned from our respiratory unit, right? You have your gastric ulceration, hyperglycemia, adrenocortical insufficiency, thromboembolism, increased susceptibility to infection, and you also have anxiety and mood swings, fluid and electrolyte imbalances, hunger and insomnia, and osteoporosis. You also have decadron or dexamethasone and solumedrol or methylprednisolone. Then you also have prednisone. So sometimes it is doctor's preference, but also there are instances where you see certain medications prescribed more often. So decadron or dexamethasone, you will see it after spinal surgery, and the methylprednisolone, you see it administered in cases of respiratory problems, so to aid in the rescue drug. And prednisone, you will see it administered in the outpatient setting. So again, you can review Unit 4 for more detailed information, and the drug choices depend on the patient, the specific problem, and the healthcare provider. Next drug that we're going to talk about is Florinef or fludrocortisone. Fludrocortisone mimics the endogenous aldosterone or mineralocorticoid. So it mimics endogenous aldosterone, a mineralocorticoid. This enhances sodium and water reabsorption in the renal distal tubule. So similar to aldosterone. Mineralocorticoid, from the name itself, right? It has to do with the minerals, the fluid and minerals, your electrolytes. Therapeutic effects of this drug include increase in sodium and fluid retention, therefore causing increase in blood pressure. In addition, this is also for pituitary corticotrophin excretion. So this hormone is produced by the pituitary gland, which stimulates the adrenal cortex outer layer to secrete steroids in response to stress. So indications for this drug include replacement in Addison's disease. If we can recall, in Addison's disease, there is a deficiency or lack of cortisol hormones. So again, Addison's disease is an autoimmune response wherein the adrenal glands do not produce enough cortisol and aldosterone. So this medication is used in that case. And sometimes this is also used for other conditions that cause salt depletion or low sodium levels. So some precautions or contraindications are hypertension, congestive heart failure, and renal impairment. So why is that? So if you look at how it works, right, and what are the therapeutic effects, it does increase blood pressure. So we have to be very careful. If somebody's already hypertensive, do we really want to give it to that kind of a patient, especially if their blood pressure is not under control? Congestive heart failure is basically the inability of the heart to pump the blood efficiently or effectively. So there's pooling of blood and it causes excess fluid or congestion. And so when you look at how this medication works, right, so it retains more fluids, you have to ask yourself, is this good for somebody whose heart is not pumping blood effectively? Most likely it is not, right? Because then we have to make the heart work harder. So that can actually cause an exacerbation of heart failure or a worsening of heart failure. So we have to be very careful, and if we can avoid it, then we should avoid it, especially if there is an acute exacerbation of CHF. And lastly, renal impairment, right? If your kidneys are not working properly, do you really want to have extra fluid and more salt in your system? Most likely not. Side effects: hypertension, CHF, edema or swelling, hypokalemia or low potassium levels, and alkalosis. Nursing actions include ongoing assessment for both therapeutic effects and side effects, definitely patient and family education, again, follow-up labs when needed, especially electrolytes and glucose, especially these hormones can affect electrolytes and our sugar levels, as well as ensuring GI protection, especially considering the corticosteroids can cause GI ulceration. So in that case, we may need to consider giving medications to protect the gut. Also, we have to monitor for fluid volume status. So we need to have a very accurate intake and output documentation and monitoring, and also monitoring for possible infection, right? So if we can recall from the previous unit, corticosteroids can actually increase susceptibility to infection. So our assessment should be very detailed, and we have to assess for those possible side effects or adverse effects of these drugs, as well as obviously the therapeutic effects.